right, thank you very much. Good afternoon, everybody. I am grateful to the organizers for selecting this for oral presentation. And my name is Christian Ramers. I'm going to present to you about our simplified and integrated HCV testing and treatment algorithm for unhoused people who inject drugs. This is a picture of where this study was conducted in downtown San Diego amidst an encampment where our organization has been conducting a syringe exchange for the last 23 years. For transparency, this study was conducted in 2020 to 2023, during which I was an assistant medical director at Family Health Centers of San Diego. This is also an investigator-sponsored study from Gilead Sciences, and as of 4.5 weeks ago, I am now an employee of Gilead Sciences. Background here is that I think we all agree achieving Hep C elimination will require broad harm reduction coverage and higher rates of screening, linkage, and treatment in people who inject drugs. And despite current efforts, HCV incidence in this population continues to rise in many locations, including this very population in San Diego. Natasha Martin's group has described that essentially the incidence of hepatitis C in this population is greater than the number that we are treating. And in San Diego County, there are about 40,000 people with hepatitis C. Family Health Centers of San Diego is a safety net clinic system of 27 clinics. And over the past 5 years, we've developed, past 10 years, I should say, a really well-developed clinic-based hepatitis C treatment program with support from the CDC, the California Department of Public Health, a Gilead Focus grant, and we have 11 primary care providers who are really expert HCV treaters embedded across 5 clinics. HCV navigators, a transplant hepatologist, myself as an ID provider, sonographer, and really elastography, including 2 portable mini fiber scans, has really allowed our program to grow in the clinic setting. And we've cured now probably 3,000 people of hepatitis C in the clinic setting. However, really acknowledge that there are populations that we were not reaching, namely our large homeless population in San Diego, which based on the last point in time count from last year is about 8,500 people that are freely unhoused in downtown San Diego. And so combining this with our clean syringe exchange program, which has been running for 23 years, which does Narcan distribution and clean syringe exchange, referrals to medical care, mental health, housing, and other social services, we felt like this was the untapped population that needed our help. And so our aim was to determine the effectiveness of using a simplified HCV algorithm coupled with integrated care for people who inject drugs, which I'll describe in a minute, delivered in a mobile medical unit, which I'll call an MMU, to increase the number of patients who initiate treatment compared to a concurrent control group, which is usual clinic-based care. This was a pragmatic, randomized comparative effectiveness trial, and I want to emphasize the word pragmatic. We had 0 incentives. This was embedded into our usual model of care. Every single patient had to have their care and their medicines paid for by their own insurance. And these were billable visits in the midst of a service enterprise, really, treating people where they were on the streets. Really broad inclusion criteria. We aimed to enroll 200 people that were Hep C antibody positive, and really they just had to be above age 18, willing to undergo treatment, and plan to stay in the area for 6 months, and only excluded those who had undetectable HCV RNA, really nobody that had life expectancy less than 6 months, who were pregnant, and then decompensated cirrhotic patients, in the opinion of the clinician, were excluded as well. And again, the setting was our pop-up syringe exchange, which every Tuesday night is at 16th and Imperial in East Village neighborhood of San Diego. The clinicians were allowed to choose which treatment they used and also the follow-up schedule and which labs to do. And we did have a team of ancillary support case managers and harm reductionists and navigators. This is my schematic of our model of care. It's actually quite more chaotic than it looks on this slide, but our typical syringe exchange is 200 people that literally line up and kind of run through this van-based syringe exchange, which has had things added to it over the years, including Narcan distribution and drug testing kits. We had a caller, sort of a person that would sort of work the line and inform our clients that there was abscess care, medication-assisted treatment, low-threshold bridges available. We give a 7-day buprenorphine bridge, no questions asked, really, and then HCV testing performed using an OraSure test. So we anticipated about 15 tests per night. At that time, the person would be very quickly consented and then had their registration and their insurance investigated at that time, and then educated about abscess care and MAT bridge services while they're waiting for their hepatitis C test result. Those who were positive were randomized to clinic-based care, which is our usual standard of care, or fit into kind of a rapid pop-up schedule where we were also seeing people for buprenorphine, MAT bridges, and abscess care. I will say this is sort of the schema of what we thought we would have. It turns out that we were overwhelmed with demand for MAT. And in fact, this program, which started as a research grant, is now self-sustainable, really providing low barrier MAT services to the people of San Diego. Our workup, which I'll describe on the next slide, we simplified as much as possible. And I'll show that on the next slide here. So it's a humbling experience to really show how many barriers your own process actually has. So in our clinic-based treatment algorithm here, we would start with rapid or a phlebotomized sample. Patients would have their round of labs done in the clinic, usually on a second visit. We would do shear wave elastography or transient elastography on every patient that came in. And then at the time, our Medi-Cal typically would require an abdominal ultrasound. Thankfully, this has now been a requirement that's removed. And then it was really visit 4 or 5 that patients would start their soft vel or glipib. We typically did monthly follow-up visits and then would have our SVR12. The integration part of this is that we felt like addressing the needs of the people, the unhoused people, would be to integrate harm reduction, MAT as well, and then wound care if patients needed it. And so we got down to essentially a 2-visit startup here, which is just doing the rapid test, drawing blood via phlebotomy for HCV RNA, as well as the other things which are really required by the AASLD simplified algorithm, including a metabolic panel, HPV serologies, and an HIV test. And then by visit 2, which on average in this trial was about 2 weeks after that initial visit, we would essentially give the medications after we obtained them from the pharmacy or the patient did, and then dispensed variably depending on what the patient wanted, either every week, every 2 weeks, or every month. The primary outcome here was treatment initiation. We didn't really have the staff or the resources to chase after everybody and make them come back for SVR12. We felt like the literature and the MinMon study have sort of showed that if people will start their regimens, most will finish and many will be cured. So defined as initiating treatment within 6 months of follow-up, and then there's the secondary outcomes as you can see there. So overall, we tested 426 individuals. Again, this was during COVID, very challenging conditions. 47% of those that we tested were antibody positive. So really, if you want to find HCV patients, the syringe exchange is a really good place to look. Of those who were positive, you can see we already have a drop-off from 201 to 150 who were able to have blood draws. And I think Megan mentioned that phlebotomists we work with are incredibly talented, and still we could only get blood from 75% of the patients. And this is with their help, allowing them to even assist us with the blood draws. And then among that, we were kind of surprised, only 63% of those patients were viremic, so 94 out of the 150. Here's our table 1, basically our demographic table. I just want to point out that 100% of our patients were currently injecting drugs. Oops, I went one too far. Okay. Many of them within minutes to hours of the actual visit to us. So very actively injecting panel, and I would say most of them injecting a mixture of fentanyl as well as stimulants at the same time. Also, I want to point out that 92% or so of our patients were actually unhoused, so this is really a homeless population. As you can see in the randomized groups, the usual care and the MMU, basically equal demographics on both there, and same thing with respect to ethnicity and then employment status as well. So the main results are on the next slide in the cascade here. And as you can see, we have drop-offs that are quite precipitous really at every step of the way, but keep in mind that the main outcome of this trial was between the viremic to the prescriptions of therapy, and there really was quite a split between the two groups that I'll get into in a second. As you can see, there was about a 25% loss right off the bat because of phlebotomy being a requirement really for our insurance coverage. 37% were aviremic, which is not really a loss, it's just sort of a fact of the population. And then again, a 54% loss going from those that were actually viremic to those that were prescribed, and that I would suppose is related to the 2-week gap that we have in getting insurance coverage for our medications. And for this study, we didn't really focus to the right side of the cascade. When we break these down by the two groups, the mobile medical unit in purple and then the usual care in gray on this slide, you can see that the losses were really quite different, and focusing in on that specific from the viremic patients over to those who were actually prescribed and then initiated care, differences that were numeric but not quite statistically significant due to the low numbers between the two groups. You can see in a Kaplan-Meier demonstration of this that most of the benefit from the MMU care was really early on, especially in the first month or so, where those that were going to be started on treatment were started relatively quickly. Kind of a silver lining and unexpected benefit of this was the buprenorphine and the MAT that we were able to provide as well. So 10% of the overall group, and it actually ends up being 20% of the overall group, initiated buprenorphine-based medication-assisted treatment as part of this trial, showing the benefits of integrated care. And then half of those who started persisted for more than 6 months, really coming back to the mobile unit over and over again for refills on their MAT. So in conclusion, deployment of a mobile medical unit to a syringe exchange site, serving unhoused individuals and offering a suite of drug user health services, including abscess care and MAT, may increase initiation of HCV therapy. However, I'm not going to kid anybody that these numbers are way lower than we've seen in published clinical trials that purport to be real world. I feel like this is a really, really real world situation with unhoused individuals. And despite faster pathway towards prescriptions, persistence and completion of therapy was low in both groups due to loss to follow-up. And just my speculation here is that external factors such as police sweeps, which became part of the reality in San Diego because there's now a camping ban, and so unhoused individuals are getting swept every once in a while. The COVID-19 pandemic, obviously. We were competing with a nearby paid and incentivized research study that was not offering treatment, actually. And then known and existing barriers such as the lab-based HCV RNA testing, the 1 to 2 week delay for DAAs, consistently and persistently undermine elimination efforts. So finally, additional steps are urgently needed to more closely approximate a test and treat model using hopefully not phlebotomized blood, but fingerstick blood to improve treatment initiation and completion rates and achieve elimination goals. And I'd like to acknowledge the syringe exchange staff at SafePoint, which has been working for 23 years with this community and really has deep and profound trust. And the overdose response teams, we had overdoses probably on half of the Tuesdays that I was there as a provider, and many others as well, highlighting that it's not just about hepatitis C, it's about whole person health. We want to thank Gilead Sciences for supporting this study, the research staff, as you can see there, the mayor's office and the police department, which we have a strained relationship with, but that allows us to still conduct this work, and of course the patients and the clients of the syringe exchange. Thank you for your attention.
Thank you so much, Christian. I'll just look around for the room. Any questions from the room? Oh, there's one up there, if the microphone could go upstairs and maybe, oh yeah, okay.
Hey, Christian.
Hi.
In California, is the FibroScan part of your prior auth, or could you do a FIB4 or a FibroSure phlebotomy?
Good question. The question is about fibrosis assessment and whether FibroScan is required or if you could use an APRI or FIB4. So this actually, as you saw in the previous presentation, this has changed, and it was at the beginning of our study required to do some type of fibrosis assessment. It was sort of, I'd say, insurance company by insurance company, whether they would accept an APRI or a FIB4 versus a FibroScan. We are now thankfully in the place where none of that is really even necessary. So it's really clinician's choice. We still think that it's good practice to do a fibrosis assessment, but those barriers are now gone. We still do bring our FibroScan out to the streets because we think it's a valuable assessment to do at that time.
Great question. And maybe just a quick follow-up. I know there's a couple of questions here at the front as well, because as we design these studies and go through ethics, and then the landscape changes, right? So then, you're designing studies that may or may not be relevant at the time. Two really important things that I appreciate greatly is thank you for doing the bridging program. I think that's absolutely wonderful. No questions asked, super important. Thank you for giving people the choice of how much they want dispensed. I think that's also something that we sort of sometimes decide for patients, and it's really important. One question that we've seen in our RCTs is that as the landscape has changed, and I wondered if it happened in yours or if you knew, but those people who didn't go to usual care, you mentioned the study that was not doing treatment. We sometimes see that those participants that are randomized to usual care find kind of like another low barrier program. Do you know if that happened for you folks at all?
We don't, and I think it's because in our usual care arm, most people were just lost. They really just never made it into the clinic. And so this is a pragmatic trial. This is what happens in the real world. They just never came back. And so we don't really know what happened to them. Yeah.
Thanks.
All right, thanks. Jason Grebley from Kirby. Amazing work, Christian. I guess I have a hypothetical question. It's not very research-based, I guess. So if you were to start again or start tomorrow in your next plan, so what do you think your package would look like? Would it be a combination of point of care, RNA, starter pack, and maybe incentivization? And I'll say one thing about the MinMon. I think that's a much more, even though there were a lot of people who inject drugs enrolled, I think we need to be careful, because I think we're running an incentivization trial, and actually MIM here is one of the sites, and we're giving 200 at start, 200 at end of treatment, 200 to come back for cure, and we're still seeing that we went big, and even that's not enough to get people back for the end of treatment and those cure visits. So I think it's going to be a big thing that us as a field need to kind of work. What is going to be the package of things that we need to kind of offer to get this most marginalized population treated?
Absolutely. I think, you can look at this cascade and be really disappointed about how steep it is, but I think what it really allows us to do is say, what is going to make the difference? And point of care testing absolutely can change that gap, and that 2-week sort of loss, like huge losses from people just not coming back. And we know from the HIV literature that leaving with a pill in your hand or in your mouth is a powerful incentive in and of itself. So absolutely point of care testing. We still have to work out getting the Hep B surface antigen testing and also a metabolic panel, although I know there's work that sort of doesn't do that, and it's probably safe anyway to do it later. So point of care testing, yes, definitely. And then starter packs, absolutely. The whole principle of why hepatitis C compared to Hep B and PrEP and HIV treatment, we have starter packs and we have samples. I don't quite understand it. Maybe now that I work for Gilead, I will. But I think that's absolutely important. And then to your final question, yes, the more sort of quote unquote real world studies that I read, including Simplify and Grand Plan and all these other ones, they all have incentives. Yeah. And we made a real purposeful decision here to not incentivize any of this, to see almost like how bad could it actually be if you just did this in usual care. Because the reality is that research studies create this real rarefied environment that is not the real world. And an FQHC like this has to deal with the overdoses and getting people housed and doing the primary care and all that other work, and you just can't directly translate research to what's happened. So that's why I would explain our results are as steep as they are in the cascade. And yes, maybe incentivizing is just going to be a reality that we have to do.
Thank you so much, Christian. We'll have to hop to the next presentation. I'm so sorry. Hopefully you can connect after.
I just need to say, I think words matter, and I just would like us to use reimburse instead of incentivize, especially when talking about a socialized, marginalized population, because we are actually trying to offset financial hardship for them to participate in these things. I was a comment more than a question.
Thanks again, Christian.